Okay, so we're going to jump into section 5D. It's bradycardia for adult and pediatric. Just a simple reminder, remember that bradycardia is going to be your slower heart rates. Tachycardia is going to be faster. So for this section, for the purpose of this section, we're going to be talking about the slower heart rates and how we will treat those patients. So if you look over, again, you have your treatment priorities box. You have 4 treatment priorities in there: vital signs, IV access, analyze your rhythm, and then your rhythm-specific treatment. As far as for EMD, EMR, EMT, intermediate, and advanced, nothing's going to change from your ACS protocol. So you're going to do exactly the same thing. Where it starts to change is when you scroll down here and you hit that paramedic box. So for the paramedics, you're going to be the ones interpreting these rhythms. So before we get started into these rhythms, if you look over here on the left, there's another yellow box, and it says unstable symptomatic bradycardia is defined by any of the following symptoms. So there's 6 things in here: dyspnea, chest pain, weakness, altered mental status, hypoxemia, and pulmonary edema. So if there's any of these things with a bradycardic rhythm, they can be considered unstable. So keep that in mind as we start going through this section when we talk about stable versus unstable. When you went through paramedic school, I'm sure you remember unstable was when you're going to use electricity. Stable is when you're going to use medications. So that kind of still stays in play to a point, but just keep in mind those 6 symptoms right there are the 6 symptoms that can define you as an unstable or symptomatic patient. So we go back over here to this blue paramedic box. It says analyze and treat per rhythm flowchart below, and it's going to go in one of 2 directions. So it's going to go to the left here for a low degree heart block or a sinus bradycardia, or it'll go to the right for what we call high degree heart blocks. So we'll start on the left here. You got your sinus bradycardia, which is going to be your normal sinus rhythm, but it's going to be slower than your normal sinus rhythm. So it's still going to be regular. Your P waves are going to be intact. QRSs are fine. Really no abnormalities other than it's slow. So that's your sinus bradycardia. Slow per textbook is less than 60. Just keep in mind that some people's heart rates literally are less than 60 all the time. Some can be anywhere from 40 to 50 on a pretty regular basis, especially if they're sleeping or not moving around or they're resting. So keep that in mind. Your first degree AV block is going to be when your PRI starts to get longer, but it will still be consistent. So it's going to be the same on every single complex. So you're just going to have that little bit of a gap between your P wave and your QRS complex. Your second degree AV block type 1, which is your winky block, is when you're going to start seeing that P wave. It'll be regular. It'll be a little bit longer on the second complex. On the third complex, it'll be a little bit longer than the second complex, and then it'll drop. So they say, I think the saying in school is like short, medium, long, drop, you got a winky block. So the key thing in interpreting any of these rhythms is going to be finding the P wave. Is it the same on every complex? Does it space out? Where's it at? What's it look like? Is it regular, unregular, or irregular, anything like that? So that's your second degree type 1. Your second degree type 2, you're still going to have that drop of the complex, but your P waves are going to be regular. They're going to look the exact same on every complex. Your third degree AV block, your complete heart block, is going to have disassociated P waves. So your P waves are going to be all over the place. So your third degree AV block is obviously the worst one. Some third degree heart blocks that I have ran on personally, they're ANO times 4, they're talking to you and they're not complaining of anything. Those are the patients we're just going to transport emergent to the hospital and tell the receiving physician what we've got, give them the rhythm, whatever we've got to do. But kind of jumped ahead of myself on that. So let's go back to the sinus bradycardia first degree and second degree type 1. If that's your rhythm analysis, you're going to go to this next box. So for asymptomatic patients, it's just going to be the monitor. You're just going to monitor them and transport them. For symptomatic patients, and you see the blood pressure there of 100. If they're symptomatic, then that's when we're going to start to treat these patients. So for pediatrics, remember for their blood pressure, it's 70 plus 2 times the age in years. Said that several times, so probably important for you to know. So that's how you figure out your systolic blood pressure for that. And then you go down. So for ACS, treat per protocol 5C. For acute coronary syndrome, we're going to avoid atropine in a heart rate greater than 40. So if the heart rate's greater than 40, we're going to try to avoid, or not try, we will avoid atropine. Do not give atropine to these patients. If you go down one more line for non-ACS, then we will give atropine at 0.5 milligrams IV push, IO push, and we can repeat every 5 minutes to a cumulative dose of 3. So we'll never give more than 3 milligrams of atropine unless you're being told to by a doctor. For pediatrics, we're not starting with atropine right away. It's going to be epinephrine for your first line medication, and it's 0.01 mg per kg IV IO push, 1 to 10,000, 0.1 milliliters per kilogram IV IO push. So, and with epi, you can repeat that once. And then if epi's not working, if it, like on that next line, it says if unresponsive to epinephrine, that's when we're going to go to atropine, and your atropine dose for pediatric is going to be 0.02 milligrams per kilogram IV IO push with a minimum dose of 0.1, and your maximum dose is 0.5. A little trick to remember, majority of pediatric doses, for your max single dose, it's usually going to be your minimum adult dose. So that's just something to keep in mind. And then you can repeat that once. But remember, again, with pediatrics, just use your hand heavy. It'll save you, especially late nights or crazy days, anything like that. It just helps you not make simple, honest mistakes, and allows you to get the correct dose and shows you how to draw it up and everything appropriately. So now we hop back up, and we're going to go to the right on that paramedic box where it talks about second degree type 2 and your third degree heart blocks. And we're going to skip that middle box. And you see the arrow on the very right side. It's going to go all the way down to the bottom, and it says adult and pediatric asymptomatic, monitor and place the pads. So for these high degree heart blocks, again, remember your low degree is going to be your second degree type 1 first degree, and your high degree is going to be your second degree type 2 and your third degree. So for high degree heart blocks, regardless of how they're presenting, it's always better safe than sorry. Just go ahead and put the pads on them, because again, if they're stable and they become unstable, you're behind the 8 ball if you don't have the pads on them. If they are unstable, then we are going to pace them at 60 beats per minute instead of atropine. Atropine will not work on high degree heart blocks, so we're not going to use it. And then even for non-ACS patients, we're still going to pace them at 60 beats per minute instead of atropine use. For pediatric patients, we'll just place the pacer pads, and then we will contact online medical control. And if they tell us to pace the pediatric patient, then we will. If not, then we won't, and we'll just transport emergency or give whatever medication that they're going to instruct us to give. So again, remember that with pediatrics, you have to consult online medical control. And then for adults, one more time, we'll pace them at 60 beats per minute like we talked about in the video prior. That's pretty much it with bradycardic rhythms. It's pretty simple. Can seem a little bit complex, but once you start to figure it out, it's pretty easy. If for whatever reason, if you're struggling with rhythms again, feel free to contact myself or Sergeant Hanlon or anyone at EMS. We have plenty of practice rhythm strips that we can go over, books that you can read that help you better understand it. Heart blocks are not hard. They can just be confusing at times, especially when you start running into different ones. So just keep that in mind. Again, as always, if you have any questions, feel free to reach out.